morning. Our speaker today is Deborah Patterson, and she was born on a farm in Saskatchewan, Canada. She and her mother and her grandmother did the cattle and the vegetable gardening, while her father had a union job in town where he could earn enough to send her to college, the first in her family. The college they chose happened to be in South Dakota, and that eventually led to marrying and staying in the U.S. She went on from her BA to earn 2 master's degrees and a doctorate in theology. Deb Patterson's story is the pie in the sky dream of most immigrants. A straight path to citizenship, no quotas, no prejudice, no deadly risk crossing the desert to get over the border, no constant fear of deportation once she was here. Rather than feel entitled by all that, she fights for social justice for other immigrants. Deb and her husband Steve, a professor at Willamette, who has spoken to ICL several times, are the parents of 2 immigrant children. Their son, who's a junior at Willamette, and their special needs daughter, who is an assistant teacher at the YMCA. As you can understand, Deb is a leader on the Intellectual and Developmental Disabilities Committee in Marion County. She is also an ordained minister in the Congregational Church. That's the church that Barack and Michelle Obama attend, and the church of the first out gay minister in, catch this year, 1972. That's a liberal church. Currently, she is pastor of a tiny church in Smyrna, where she serves mostly elderly, low-income parishioners. I can tell you, because I've been there, she is their first responder when any one of them needs help, and sooner or later, they all do. With that impressive background, her topic today is health care. What does she know about health care? Well, 20 years she spent developing and managing nonprofit medical programs in national and international settings. She is a passionate advocate for all those who cannot find affordable medical care. Please welcome her to ICL.
Thank you so much, Ann. I did have to cross North Dakota to get here, and that was a challenge. It was hot, it was the summer. So anyway, it's wonderful to be here. I know a number of you, and it is a pleasure to see the others of you who are here. My dream and hope is to be an ICL in just a few years myself, so thank you very much for letting me join you today. I'm trying to figure out, if I stand here, will you still be able to hear me? Okay, then I can see my slides as well. I'm going to be talking about faith community nursing this morning, which is the area in which I spent most of my career. I, as Ann mentioned, studied theology, and one of my masters is in healthcare administration from Washington University School of Medicine in St. Louis. I was the executive director of the International Parish Nurse Resource Center for 10 years. That was an organization that had registered nurses as partners, and I'm going to talk more about that this morning. Before that, I was the founding vice president of a children's health foundation in St. Louis, and before that, I was the vice president for mission and ethics of a health system called Deaconess Incarnate Word Health System, which had 3 hospitals and 100 physician practices. So healthcare with justice has been my issue for my passion, my driving passion for all of my life, and I continue to work towards that today in other ways. So what's old is new. I would like to talk about community-based healthcare from womb to tomb, and you'll see what I mean as we go along. We remember this guy. Who's this? Marcus Welby, MD, right. And the model that he offered was he was a general practitioner, not a specialist. He lived where you lived, in the town where you were living, and you went to see him when you got sick, and if you were in the hospital, he came to see you. Not like today when usually you see a hospitalist, right? You don't necessarily see your own primary care physician in the hospital. He knew you, but he probably also knew everybody else in your family. You trusted him, and so did everybody else in town because he was the doctor for the town. Before the 1940s, you would have paid Marcus Welby directly by he'd send you a bill, you would pay it. After the 1940s, when health insurance became more employer-based and everyone got on board with health insurance, your insurance would pay his bill directly. You wouldn't lose your home when Marcus Welby sent you a bill. You wouldn't go bankrupt if you couldn't afford the cost of your care, because he would make sure that it was affordable care. You didn't have a long way to see him, and guess what? He made house calls. So what's the model we have today? Most of our doctors are specialists. There are fewer than 1 in 3 doctors today are primary care physicians. And for example, in places like the Veterans Administration, the VA system, they really have a huge shortage of primary care doctors. There's a great need for more primary care doctors in our American healthcare system. Also, most of the doctors in this country live in cities. So if anybody, I realize we live in an urban area, but for folks who live in rural Oregon and other rural parts of our country, there is a huge shortage of physicians. For example, in Sweet Home, there's one healthcare provider who's at a specialist level, and that's a physician's assistant, not even a physician. The model is, in our healthcare, you take care of yourself, and then you go to the doctor when you're sick. He won't come to you. There is some concierge medicine now where you can privately pay to have someone come to you, and so now there's a little bit of telemedicine, and some of the doctors will email you, which is really cool, but mostly it's do it yourself and then go to the doctor when you're sick. Now, I wonder if any of you have experienced this. Have you had to change doctors because your doctor retired? Yeah, I mean, doctors are young these days, aren't they? They are so young. They look like Doogie Howser, everyone, almost. I'm always worried that the doctors I've had for a long time are going to retire soon. It's hard to find a new primary care doctor, and often we end up seeing many different doctors, even primary care, over the course of our lives. We spend a lot on our healthcare system, about 18% of our gross domestic product, and we don't, which is more than any other developed country in the world, and we do not have the best outcomes compared to other developed countries. We're down the list quite a long ways. Italy is number 1. So we have a patchwork of providers and insurers in our country, and communication between all of them is sometimes tricky. Here was where things started to change, a new model called holistic health centers. In the 1980s in Chicago, a group of people got together and got a grant from the Kellogg Foundation to start a series of holistic health centers. It was a model where you would go to a place where there would be a health team to provide wraparound holistic health services to you in your own neighborhood. They chose churches, not because it was a Christian thing or anything, it was just, they chose it did have a faith component, but the reason they chose churches was because they were there in the neighborhood. The small town where I used to be a pastor years and years ago had churches and bars. Well, there was more room in the churches, and most of the week the rooms sat empty. So they had health care places right in the neighborhood, an anchor where people could go. The team had 5 people. They had a doctor, they had a nurse, a social worker, a chaplain, and as an ad hoc member, the minister of the church. The model had to change, though, because doctors are their salaries are higher than nurses, right? So they were kind of too expensive. The person who really got the connection between the healthcare, the hospital, and the doctor and the community was the nurse. So if you have to strip away everybody else in healthcare, in community-based healthcare, the person they stuck with was the RN. That was the model that survived. And a new profession was born from this early grant out of the Kellogg Foundation. It was called parish nursing for the first 25 years because a parish, you know this, quiz. A parish was supposed to not only include the people who go to your church or your faith community, the parish was, like Louisiana, the counties, the parish was supposed to include the area around your church. Those of you who are Catholic have that concept that a parish includes the people beyond as well. And so the point was not just to provide health care to the people in that faith community, but to reach out and was also inclusive of other faiths, which is why they chose to change the name to Faith Community Nursing. Now, these are nurses with a lot of experience. As you can see here, the head of Faith Community Nursing in Swaziland used to be the head of their Red Cross for the whole country. The head of Faith Community Nursing in England is the chief nurse there. She's the former national nurse. We have a surgeon general. We don't have a national nurse. But England has a national nurse, and that's who is the head of their faith community. These are nurses who've been around, seasoned nurses who really got tired of walking up and down the wards and taking care of people. They wanted to get out in front and help people stay healthy and keep them out of the hospitals. And so they got really energized about the preventative kind of things that they could do. So what they do is they offer culturally competent health assessment, education, healthcare navigation and advocacy, and resource referral for all ages, womb to tomb. Because in congregations, no matter what faith, we served Christian, of all denominations, Jewish, Muslim, Buddhist, First Nation faith communities. These are places where you will find people who are pregnant to people who are dying. You'll find, newborn infants all the way through the lifespan. So this is a place where healthcare can be health promotion and these other services can be available to people of all age groups. We primarily spend our lives very segregated by age, don't we? Even in schools, the 6-year-olds are separated from the people in the next grade up in the second grade. So this is a place to reach everyone. As far as health assessments, the nurses offer screenings, and those they can't offer because they might be more specialized or invasive, as in giving needle pokes and things like that. Then they bring in outside screening organizations like to do vision and bone density scan, blood sugar screenings and things like that. They will come to you in your homes and help you do a personal health assessment. They also screen for depression, which is hugely important in our communities for all ages. They won't diagnose your disease because they're not doctors. But they will tell you, they'll give you advice to say, we think the nurse, I think that you have a health condition that you might want to go see a doctor about. And one of the things I've noticed in the years that I've worked with faith community nursing, that the first people to find their faith community nurses in a church are middle-aged men, because they don't go to the doctor enough. They don't get things checked out. So they go up to the faith community nurse and say, hey, can you take a look at this and see what you think this is? Then the next group that finds the faith community nurses are parents of teenagers, because those are challenging years, and parents are worried about teens and how to help them. Then seniors, and then everybody else. So they serve everybody. It's really exciting. They also are qualified to look at things that might be risk factors for health concerns, and loneliness is a huge, one of the top risk factors for getting sick. So they're watching for that, and places like ICL, places like faith communities are places where you're socializing, and that's a wonderful intervention to pull someone into involvement for I'm going to tell you a quick story about that. There was a faith community nurse who she was part of a large staff, and they took turns visiting different people. And one day, as they had their staff meeting, this nurse found out that she was assigned to go visit Edna that day. Well, nobody wanted to visit Edna because she was cranky, but she lived alone, and so everybody said, we'll take a turn to visit Edna. So the nurse knocks on the door, knock, 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 knock. Edna goes, what do you want? She says, well, I'm just here to see how you're doing. And she says, I'm fine. And then she said, the parish nurse said, you know, Edna, there's a new mom in town. She doesn't have any family. She has a little baby. Would you be willing to make a casserole for her? And I'll take it over to her and tell her it's from you. And in this state, this was in Indiana, they had to write the ingredients of what's on the casserole by law and then put the name of the person who made it so that it was a health requirement there. So Edna says, okay. And she makes a casserole. The parish nurse picks it up the next day, takes it over. Okay, so a few weeks go by. It's the rolls around, time for the parish nurse to go visit Edna. Knock, knock, knock. Edna answers the door. She says, what do you want? She says, well, I'm here to see you, Edna. Well, hurry up, because my baby is coming. Turns out that the mother, called Edna to thank her for the casserole. They got talking. She came over, brought the baby, started visiting. The nurse noticed that Edna had the baby's picture on the fridge, and they were developing a wonderful relationship. Edna had fallen in love with this new mom and fallen in love with this baby, and vice versa. And so it was a moment of healing for all of them. So it's not just about medicines, it's about a lot more than that too. So that assessment for those kinds of risk factors. Faith community nurses also offer individual and group education on health conditions, and they teach a lot of classes to get people healthy, like walking to Jerusalem. A church might decide to measure the miles between here and Jerusalem. All together, they're all going to count their miles as they walk during Lent to get all the way to Jerusalem, or Bethlehem at Christmas, for example. We employed in our local the International Parish Nurse Resource Center, when I started, we were in 6 countries around the world. When I left, we were in 23, 10 years later. But we also employed in our own office 50 nurses who worked in our setting. We partnered with about 15,000 nurses around the US and about 25,000 around the world. But the 50 nurses we had offered about 150 different health education classes. We have some in the church that I'm at right now, a memory cafe, which covers different things about keeping your brain healthy. And Ginny Furtwängler was one of our speakers a few months back, and Ann was there too. So other programs here's some examples, sex ed classes for young people, parenting classes, community gardening, and things like that. I had this aha moment partway through my work there. The growth of this work was primarily happening in 2 regions. The United States was growing like crazy. We were adding faith community nurses. It was exploding over the years that I was there. It continues to grow. It's been relocated now. It's in Memphis. But it was not growing very fast in Canada or Europe, Australia or New Zealand. It was growing really fast in Africa. And the reason why that it was growing really fast in the US and in Africa, I realized, was because our healthcare systems in both places were very fragmented and very broken, and we did not have health care for all in those 2 places. There were a lot of people falling through the cracks. Let me give you an example. One of the women that we were working with was a woman in southern Illinois whose husband had worked lifelong in a factory, had good health insurance, but this was in the days before you had limits, before they were, when they could say you're limited, right? He was diagnosed in his early 40s with lung cancer. He quickly hit the lifetime limit for his care, and not only was this woman about to lose her husband to the ravages of this very advanced disease that was rapidly taking him, but she was about to lose her home as well. So the faith community nurse went and advocated with her at the hospital, and they were able to negotiate a rate that she could pay and that she could still keep her home. This is why faith community nursing was growing so fast here. People needed help navigating their way through the system, finding the care they need, and being able to deal with very complicated financing mechanisms we have. I mean, even just with your open enrollment every year, isn't it kind of tricky to try to figure out, you want to stay on your same supplemental plan, or how should you change it? Our healthcare is very, very complicated in here, and so faith community nurses can be real helps in there. There were different plans in different places. As you well know, in the United Kingdom, the healthcare financing is government financed, and the government also owns the facilities and employs the health professionals. That's like our Veterans Administration here in this country. In Canada, each province has its own individual financing mechanism through the government for the residents of that province. But the hospitals are mostly privately held. There are a few government hospitals, and most of the health professionals are also private. They're not employed by the government. In Germany, it's very similar to the US, except for like us, they have private hospitals, and they do not employ the doctors and nurses, but all of the insurers, all of the health insurers in Germany are nonprofit, and everybody is required to be a part of that nonprofit. Our Blue Cross Blue Shield companies, organizations here used to all be nonprofit. A few of them still are nonprofit, but most of them have changed to be for-profit. So that might surprise you, because most people still think Blue Cross Blue Shield is nonprofit. Not the case. It goes on a state-by-state basis, and you need to check and find out if your Blue Cross Blue Shield is nonprofit or for-profit if you're under their care. It doesn't, I mean, it's neither here nor there. I'm not advocating one way or the other. I'm just pointing that out, that in Germany, all the insurers must be nonprofit. When Blue Cross Blue Shield in Missouri became for-profit, they had to appear before the Secretary of State there and had public hearings, and part of the settlement in order to become a for-profit was that they had to form a foundation, and they put $1 billion into the Missouri Health Foundation, which was formed by the change of Blue Cross Blue Shield into a for-profit corporation. And one final point was, all those other developed countries around there have regulated the cost of their drugs, which we do not do in this country. Medicare is by law not allowed to negotiate the prices of the drugs, as you well know. So there's a great need for navigation, healthcare navigation, and for healthcare advocacy. They also help families advocate for their loved ones. I don't know if any of you have had a parent or a spouse or a neighbor who was hospitalized and suddenly had to be discharged to long-term care. It's hard to find that on short-term notice. The caseworker might give you a list and say they have openings at these places, go try to find a spot, good luck. But the faith community nurse in a community will have already visited each of those facilities and will be able to tell you, you know, I've seen a lot of people at this place, and I know this is a very good place. Every place we lived, I told my husband, this is where you have to take me if I'm going to the nursing home. I valued their advice. And faith communities know the families, and like Marcus Welby, they are trusted by their families. Nurses are trusted more than any other group anyway in our community, more than clergy like myself, more than doctors. And these nurses will take time to visit folks at home and in the hospital and the nursing homes. One of their favorite sayings, the faith community nurses, was, faith community nursing has no length of stay. You know how hospitals will say you can stay 1 day if you're having your knee replaced, 2 days if you're having a baby, if you're really lucky. And faith community nursing has no length of stay. They're with you as long as you need them to be. And it's womb-to-tomb care. It's not fragmented. They'll help folks who are veterans apply for benefits. Sometimes it just is tricky, and folks get turned down the first time when they really are eligible. And I know of many cases where faith community nurses have helped people get the benefits that they are entitled to. They help people find providers, evaluate care, and they also help coordinate things like Edna, you know, support with meals and visitation and other things like that. Here's where I need my pointer. We often like to say health is holistic health is body, mind, and spirit. There we go. Whoops. Body, well, just imagine the roof. Okay, body over there, mind, and spirit. But really, holistic health is more. It involves the whole house. If you do not have a healthy community, if you have no friends, you're not going to be that healthy. And if our environment is not healthy, if we don't have clean water that we can drink, if we don't have clean air that we can breathe, if we have so much carbon dioxide in our atmosphere, right now we are up to 408 parts per million of CO2 in the atmosphere, and that's measured in Hawaii, not LA. And the safe level for avoiding a catastrophic global climate change for long term is 350 parts per million. We have to be involved in the health of our planet as well, and so that was an important part of faith community nursing too. Does it make a difference? Absolutely. We did one survey, we did a number of surveys, but one was a survey of 760 parishioners in 19 different faith communities, where we found that half of the people who didn't regularly get their blood pressure checked were doing so regularly. 39% were eating a healthier diet after some of the classes and the little tastings that the faith community nurses would do. They'd set out little tastes each Sunday of a different recipe and say, and here's the recipe. Take it home, it's cheap, it's easy, and it's healthy. 39% knew the warning signs of a heart attack. 35% knew the warning signs of stroke, and stroke is something that a lot of people didn't. On average, it's like 12% or 8% of the population know the warning signs of stroke. And most importantly, 32% increased their exercise activities. People got busy and got going to stay healthy. So I was all in. I wrote a number of books over the years on the topic. I just completely fell in love with the model, believed it had tremendous opportunity to change people's lives and health practices. And the story continues. The International Parish Nurse Resource Center, I left there in 10 or 11, I guess, after 10 years. And I negotiated a move. It moved to the Church Health Center. It's now in Memphis, Tennessee, and it's called the Westberg Institute. But you can see in the photo here, the woman on the far right over there, or to your left, is the director of parish nursing in Canada, then a couple more over in England, the head of different denominations. So this profession continues really to unfold. It's, to recap, it's community-based, culturally competent, because everybody knows their own community, right? A faith community nurse who's serving in their own Christian denomination, church, or their own Jewish, Muslim, Buddhist, First Nation, their own community, they know the people who they're part of the faith community with. So it's whole person care, from staying active to eating right to taking care of your health conditions to being connected. And the emphasis has been moved from having the hospital be your, the first point of entry for healthcare, to being, starting with the entry with prenatal care, womb to tomb. But in closing, I would like to add one more thing, and then we'll open it up for questions. We could have a faith community nurse in every single church and every single faith community in this country, and it would not negate the need for universal health care coverage for all. It points out, because there is such a need for faith community nurses, it points out the urgency of finding a way to get universal health care for all. in this country and beyond. So that's my contact information. For a few years, I also was, after I stepped down from running the International Parishioners Resource Center, my kids were in high school by then, and I decided to do something that was involved a little less travel. I have to tell you one story, and then we'll open it up for questions. When my kids are really little, we adopted them both as toddlers from Russia, and sometimes they would just drive you crazy. I mean, suddenly going from 20 years of not having children in your family to suddenly you have 2 toddlers who don't speak English running all over the place. Sometimes you just kind of go nuts, and I would say to them, "Oh my gosh, guys, settle down. I'm going to have to take a break and go to Korea." Well, imagine their wide eyes when we started the Asian Parishioners Resource Center in Korea. It was just serendipitous. It just, I said, no, I'm coming back. I'll only be there a few days. No worries. So anyway, but I was traveling once a month at least or more for a week at a time internationally, so I stepped down, headed up Northwest Parishioners Ministries, thinking that it would just be in, 5 states, Alaska, California, Wyoming, Idaho, maybe 6 states, Washington and Oregon. How hard can that be? Well, they're not, they're big states. So after a few years of that, I moved to this church, which I really love now, at Smyrna United Church of Christ near Canby. But I still feel passionately that we need health care for everyone, and I still believe very strongly that no matter what faith community or other committed communities you are part of, that health care delivery in an upstream model is one that really can change lives in a dramatic manner. So thank you for letting me be with you today. And I know it's almost time for lunch, but we do have time for a few questions if you have any. Oh. Yes.
I know that there are a lot of people in our community that need to get health care and don't have a clue as to how to get it. So if one person is to come upon someone that needs that kind of help, is that the phone number we use? Or where do they find what is available here, for instance, in Salem? I have no idea what it is in Salem.
Right. That's a good point. And that's what faith community nurse would do. They would, there are a number, they're based out of Salem Health. That's where they meet. None of them are employees of Salem Health. Salem Health allows them to meet there. But a number of the different faith communities here do have registered nurses on their staff who are able to answer those questions. And what they do as one of their first tasks when they first are hired is to find out what resources are available in the community. And so the answer to that question would be very different if you ran across a person who was a veteran, for example, or if you ran across someone who had Medicare or Medicaid. Thankfully, in Oregon, we're up to 95% coverage now. Measure 101, as you know, passed, and that guaranteed that the folks who would have lost health insurance coverage under the Oregon Health Plan still have that, which covers 1 in 4 Oregonians. So there's only 5% of people who don't have health insurance anymore in this state, which is very commendable. Certainly there is a free clinic down at Broadway Commons that folks can go to. They do have limited hours, but there are a number of health providers who volunteer to work there. It might be interesting to note that if you happen to have Medicare, not Medicaid, but Medicare, the difference between what a hospital would be paid for your care if you had private insurance and what they only get paid if you're on Medicare is considered charity care by the hospital. In other words, they're losing, in their minds, they are losing the amount of money for caring for you that they would be paid if you had the private insurance that you had before you retired. And so our healthcare system is so fragmented that you probably, if they did not have health insurance, you couldn't send them to any urgent care center. They would not be seen there. You would have to send them to Salem Health or in one of the other hospital ERs. By law, they are mandated to make sure a person is stable. They don't have to treat them if you're stable. In fact, there have been instances of, I mean, when I was at health administration school, we heard this horror story. I don't know how often it happens, but I do know it happens. Because my husband's grandmother was someone who experienced this personally, and they lost a child who died. If you arrive in an ER, I'll use St. Louis as the example. This was where it took place. With a gun and with a knife in your back, if you can be safely transported to the charity hospital, which was called St. Louis Regional Medical Center back then, the hospitals did not have to take you because you were stable. They just had to stabilize you, and then they could get you over to the St. Louis Regional Hospital. The laws change all the time. So to answer your question, I'm not trying to be flip, but it's really complicated. And as President Trump mentioned, it's complicated, healthcare, right? And you know, there is not a single answer. It depends on who the person is, what kinds of, you know, insurance options they might have, and what their health situation is. Yes, everybody can be seen at the ER, and the ER does have to stabilize everybody. And then they are under a fiduciary responsibility to try to collect as much as they can for towards reimbursement for their care. And we, under that system, we all wait longer when we go to the ER because they triage, right? Because the ER is so darn full. And I haven't even touched on mental health care. Yeah. So. Okay. I'm sorry I don't have, but that's why we need parish nurses who really have tried very hard to know what all is out there. And sometimes it's a simple matter of a parish nurse saying, oh, I know Dr. Reichland. Where's Kay? I thought I saw her today. Okay. I know Dr. So-and-so. I will call them and see. I mean, I did this for somebody the other day who was in massive pain from a toothache. I thought, okay, well, I know Dr., I'm not saying his name. I know Dr. So-and-so, and I will call and see if they will be willing to spit this person in and see them on an emergency basis. And I know and happen to know that this particular person did provide charity care, and so he agreed to do that. But that's not really a good system for an entire nation to provide health care in that way. Yeah.
Okay. Reverend Deborah, hi. Back here.
Hi.
I have a question that I haven't found the answer to. Maybe you could help. In shopping for the appropriate health plan for myself, I like to ask what percentage or how many claims are disallowed. In other words, the box score. How could I find that information? Because most of the places aren't willing to give that to me.
I'm not quite sure I understand your question. How do you find the best health care supplemental plan?
When you file a claim, sometimes they're accepted and sometimes they're rejected. I would like to find out what percentage and, you know, compare different companies to see who does the best acceptance rate and who has the, you know, the worst rejection rate, so I could see, because that's the bottom line. And how do I find out that information?
Right, that's a really tough question. And the fact of the matter is that there's not that much transparency in healthcare right now. I mean, that's one of the reasons why there's a transparency bill that just passed the House this week. It is now on its way to the Senate. I realize it's around pharmaceuticals, but we need a lot more transparency in billing. We don't know the cost of things when we're going in. We don't even have an estimate. We might have an estimate. And you're right, there is no way to compare what the rejection rate on different things for different health plans, because also you're not just comparing apples, it's not comparing apples to apples with, we all have different situations. Healthcare is so complex because our bodies are all different, right? And what we all need is different. And what hospitals charge for the same procedures is going to be different too. There's no standardized rates for different things like that. So go ask your legislature about that question, because I think that's really important. We need to demand transparency in our healthcare financing. You've really identified a real need there, and it's not a simple thing to answer because that information is not easily available.
Yes, I was wondering if you can give us an idea of the scale of the operation, how many patients go to these health ministries in Oregon and in the region?
Yeah, faith community nursing in Oregon is much lower than it is in other parts of the state, primarily because there are fewer people involved in faith communities altogether. In the Bible Belt, there are tons of faith community nurses in all kinds of churches, and some denominations also have really surged ahead in this. For example, the Seventh-day Adventists, who are they do not drink alcohol, and they are vegetarians. They have wonderful health facilities and medical schools like at Loma Linda in California. They have had a huge emphasis on getting faith community nurses in all of their congregations, or as many as possible. Because the pay is, it has different models. Some faith community nurses are paid by hospitals, and they get even though there's experienced nurses, their pay for this model is what an entry-level nurse would get. Because let's face it, if a parish nurse, how does a hospital make money? They only make money when their beds are filled. They want you to get better, but they also want the beds to be filled with, they need to have their, I'm gonna give hospitals the benefit of the doubt. I'm not anti-hospital. Hospitals want you to be healthy. That's what they want, but their business model is they're only going to get reimbursed for care that they provide, and you need to have people in your hospitals to get reimbursed for care. So it's not necessarily in their best interest, it's a community benefit, but they're not going to invest huge amounts into this model. The second way of paying is to have a church pick up the cost of paying salary for a faith community nurse, and most work part-time. But look at the pastors get the big bucks, right? Yeah, right. So you can't pay nurses in churches much more or any more than you pay the pastor, and they're not getting doctor's salaries. So it's a church paying for a faith community nurse, the salaries are rather low, and then many are volunteer. So it's dependent on the goodwill of nurses who feel really called to and passionately to do this. They must have at least 2 or 3 years of experience, but most have 20 or more years of experience as nurses, practicing nurses with valid licenses. And then they go through more continuing education to prepare for the specialty practice. They're in the process of putting together licensing for it now. And so it could be everywhere. But because of financial models and because faith communities themselves are dropping off, there are fewer than in some places than in others. And like I said, Africa, it's growing like crazy. Madagascar has a ton, Swaziland has a ton, South Africa, Ghana, Kenya. So it's really exciting there to see the public health things that they're doing. So, but if our public health Department of the United States was really to get behind this model financially, it could be everywhere very quickly, but that has not been part of the financing model yet. Sorry, more answer than you wanted, but thanks.
Hi there, Cassia back here.
Oh, I'm sorry, yes.
Hello, how are you?
Oh, hi.
As you're aware, the Oregon Senate recently refused to refer the healthcare initiative or referendum to the public for a vote on whether to include healthcare for all as an Oregon constitutional right. What do you think would be the outcome if it did pass, and how is it, and I'm assuming that because it won't come to the voters for a vote, it's not going to pass because the Senate doesn't want it to pass. So that will stay the same. But if it had passed, what do you think would have been the outcome on these faith-based programs and on the transparency issues in particular that were just mentioned a minute ago?
Yeah, that's an interesting question. Clearly, you can't control costs if you don't know what your costs are. So clearly, you need transparency. I happen to personally believe that healthcare is a human right. It's part of the UN Declaration of Human Rights, and so we have tied health insurance coverage to the employer since the 1940s because we didn't have the money in our government, and we didn't have the money in our economy to pay higher wages. A lot of the employers offered health insurance as a way to give more benefits to people rather than paying them more salary. So, but then we also have age-based healthcare, Medicare, and we have income-based healthcare, Medicaid, and Cover All Kids. So we have so many different models. And we have, and also veterans, depending on if you've done that. So we have, I think, more confusion in understanding our costs that will make it tricky. One, Healthcare for All Oregon is a group that is advocating for Medicare for all. And that would be one way. I don't know if any of you had trouble finding a physician if you moved to Salem who would take Medicare, but I know that many physician practices limit the number of Medicare patients they take because they're reimbursed at lower rates. And so, but if everybody had Medicare, the argument goes, is that, we would understand our costs more, and that you would be as valuable a patient to the healthcare providers as the next patient. And so it seems to me that is one very good model. I personally really like the German model. We lived in Germany for a year when my husband was working on his doctorate, and found that the choice that was available through the nonprofit plans that are regulated, with their regulation of costs by government oversight of those different plans, and the choice of providers, it was marvelous health care in that country. So I think there are a number of ways to get in a model that fits our state well. In this country, there are ways to get to health care for all. But you're right, transparency in understanding our costs has got to be a critical component of that.
Yes. When I was working, I was in Japan quite a few times, and I was very impressed with some of the institutions they had, and healthcare was one of them, because if you got sick, all you had to do was go to a doctor, and they had to take you. And I was, and other things too, but that was one of the things that really impressed me about Japan.
Yeah. Japan also is impressive in their very, 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 in another area of public health. They have extremely low rates of death by gun violence in Japan. And one of the public health measures they've done there in order to take positive step towards being able to reduce gun violence is that they actually number the bullets. And so if a gun is shot and someone is killed, they look at the number on the bullet and they see whose it was, and they, that's it. Gun violence is a public health issue, and so I think we have much to learn from other countries in a number of public health and health financing arenas. So.
Yeah, this is Ann. What if we had Medicare for all? What would happen to the pharmaceuticals? Would they still remain outrageously charging?
Well, currently, if we had Medicare for all, nothing would happen to them, because pharmaceuticals are not regulated, and that is not even on the docket right now here in Oregon. The bill that has passed the House and may go on to the Senate was asking for the pharmaceutical companies only to to report to the state if they were intending to raise the price 10% or more and in 1 year, and explain why, and also to account for their expenditures on healthcare research, pharmaceutical research and development and marketing. Like when you're watching TV, when you're exercising at the courthouse, so many drug ads constantly up there for the commercial, during the day and evening too. So other countries regulate drug marketing. We can't prescribe our own medications. Why are we paying for them to market to us? So, so that would have to change. We would have to, if we had Medicare for all and we wanted to impact the cost of pharmaceuticals, we would have to change the regulations around that. Absolutely, absolutely critical. It is crazy that we are paying $600 for EpiPens, or no, I mean, now it's back down to $400, but other countries sell them for 20 or 40, so. And, you know, frankly, from my point of view, we have paid through our taxes to keep the U of O and OSU and OHSU educating people who become scientists, who become researchers, who develop drugs, and pharmaceuticals then companies obtain their expertise, and then we end up having to pay on the other end very high prices for the drugs, where we've already paid for the education of their employees, and we've paid for, through the NIH and other research things, paid for a lot of the development of those, many of the medications in many ways in many parts along the way. So we're not getting our money's worth in this. We are wasting money.
Well, you have given us a good picture of what we do have, and that's very important for us to know, and all the things we don't know about our medical condition. I ran out of time in introducing you, but I do want to add 2 more things to Deb's credit. She is an editor, a citizen editor at the Statesman Journal, and recently she became the District 10 Democratic candidate for the Oregon State Senate. Let's thank her and wish her well in her campaign. Thank you.